all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today is our one-on-one, our heart-to-heart. Today is one of my favorite days for our discussions. A little sad today. I just spoke with John. I hope you know that his father was not well. He had COVID, then went on to a ventilator. It seemed that he was doing well, and then all of a sudden his renal profile started falling, and then liver profile. And so today, in the morning, he passed away. So rest in peace for him, and lots of grace and blessings and prayers for his family as well. I just spoke with John, and of course, it pains me to encounter these situations. I think that saying after the fact that if we did Ivermectin, his doctors had refused to give Ivermectin. If we did Ivermectin or if we did that, it would have been different. It kind of seems wrong to me to say it when somebody has passed away. But I think that one thing, I was just looking at this news on CNN, and I'm sure it is a similar news everywhere. So it's nothing about politics. US likely to face grim months before vaccines, experts say. And I am just shocked and surprised and angry that those possibilities that are simple, that are cheap, that are available, that are safe, that have been approved for many other reasons, why are these not backed up by the CDCs and FDAs? Why can they not even think for a single second to offer hope other than these silly words that they mutter on TVs the whole day long? They can go ahead and say, give Ivermectin. They can say, give hydroxy or zinc, and take care of the patient and look at the patient's situation and see if the patient can get this or not. Here is the protocol to make sure that they're not pregnant, or there's not a small child, or they don't have cardiac arrhythmias or the bleeding disorders. So they can put that whole thing together and then put it out and say, with these safety indicators and with these safety measures, go ahead and try to help. Why not say give vitamin D? Why not say give vitamin C and other things? This is really what makes me angry, that I used to say they are indifferent. I have reached a point of thinking that it's not even indifference, it is deliberate ignorance. So it just makes me very mad when I see these things. So let's start our discussion. I didn't even set up my things correctly. I was so upset. So let's start our discussion. So this is drbeen.com. If you wanted to have access to these lectures or other, please take advantage of them. Nowadays, we have a couple of sales going on as well for holidays, so you can purchase if you like. This is the Twitter thread where we would have our discussion. Before that, I wanted to give you one more update, and that is about the fundraisers that we are doing. So there are two fundraisers that are continuing. One is for Nina's health insurance, and the other one is for the book. And I had said that yesterday that my preference is to do the health insurance first. So I wanted to share. I just saw the updates before the meeting, before the discussion here. So one, I want to thank Margaret. She has contributed $600. And I just saw there is another person, her name is Janet. She just contributed $500. And then there was lots of good, generous people. So I think we have reached about $1,500 or $1,600 out of $2,400. So we are almost there, and I would wait for a couple of more days, and then if there is any shortfall, then I would fill that in from my side, and we would buy her health insurance. She called me this morning. She was very, very grateful. She was grateful just for the thought of it, that there are people who are thinking of offering her hope. And she discussed very briefly about her past and how others may not have cared for her. She's a janitor in a grocery stores. She has multiple sclerosis. She has a couple of other chronic illnesses because of which she cannot do something that gives her more money. So she is earning low, and she was quite grateful for what the Cool Beans are doing. My next steps are that once the 2400 is done, I would send that money over to her, and I would request her to buy the health insurance for the year. So thank you very, very much to everyone. Anyone who has donated $5 or $10 or $500 or $600 or $100, that all is so precious, and I'm so grateful for that. The other one is the book GoFundMe. That is in the beginning phases. I would have preferred the health insurance first. So we'll see as that matures later on. So with this, let's start our discussion. Here is a thread. The very first comment here, Lucky Dog. Is alpha-lipoic acid useful to repair organ damage from COVID? Dr. Bert Bergson uses alpha-lipoic acid to repair liver and other organs. So Lucky Dog, beautiful question. And I wanted to talk about the mechanism itself, and I thought this was not the right time to do it. So what I'll do is this: I'll respond to you that yes, there is a potential for that, and then we'll talk about the mechanism as well. If for some reason I forgot, it will not be a deliberate thing to not do it. If for some reason I forgot, please just remind me on Twitter, and I would get to it. So this is one. Then there is a Cool Bean 38. I love it. So that means there are 380 Cool Beans already. So Cool Bean 38 has this video. Cool Bean 38, I did not check the video. Usually I avoid going through the videos, but I thought these were very interesting and perhaps could help some long haulers. So I'm going to look at it anyways. I think it is for long haulers, this would be interesting. So if there are any long haulers, please look at this. Here's the title of the video. Here is how you treat long COVID. Then Cool Bean 38 says question. So she has, I think, multiple questions. Question number 4 are there any COVID vaccines that could cause a person to shed after receiving them? So this is a very, very interesting question, and I am going to start our discussion from here. So look, what happens is, the vaccine, when it is given to a person, so let's say this is a person, and the person has the vaccine, correct? So this is a person. So that a little hurriedly created person. So when the vaccine is given, what happens is in that person, so first dose and second dose, when you've given the first dose, what would happen is, we know this, macrophages and neutrophils and other cells, for example, dendritic cells, they will pick up the vaccine antigens, or the messenger RNA would enter the cell. These cells, or regular cells, for example, muscle cells, I've discussed it many times, so I'm not repeating it with full mechanism. And what happens is, these guys would then activate naive T cell or cytotoxic T cell, depending upon whichever cell they connect with. And then the whole immune system becomes activated. And we know that in the immune system, we'll make B cells active, and we will make cytotoxic T cell active, correct? So again, I'm describing it in very brief way because we've talked about it many times. These B cells then, in turn, when they become active, they're called plasma cell, correct? These plasma cells will then make antibodies. The antibodies that are made are IgM, then IgG, and then, of course, we make IgA as well. So here is where the answer is to your question for shedding. IgA's job is to go and sit down in the wet surfaces of our body, or the mucous surfaces. For example, conjunctiva, or the nasal area, or the mouth, or reproductive system, or the GIT. or the tracheal system. So when these IgAs sit down there, so let's say this is an IgA antibody. Normally they have a secretory component, and there are two antibodies that are bound together. So let's say this is IgA. And let's say this IgA is sitting in front of a cell. So here is a cell, and this is the IgA. And this IgA is sitting in the fluids, the wet things, the mucus that is in front of the cell, right? So now when the virus arrives, ideally this IgA is going to bind with it, and then it is just going to hold it. That means the virus is present here. Now, if that person coughs, that person is going to eject this virus, and the virus is going to go to other person. Question is this virus multiplied? Has this virus increased in number? Would the person who is shedding have enough load ejected that it can make the other person sick? I think that is where the shedding to cause infection may not be possible, because the antibodies are present. They are going to connect with the virus. They are not going to allow it to go into the cells and then sit down in the cell and use the cell's machinery and to replicate and to increase in numbers and then to come out and then to go to the other persons. So your question then, that are there any COVID vaccines that would cause a person to shed after receiving them? I would restructure this question to say, restructure my answer to this. When you give the vaccine day 1, vaccine has not caused the immune system to become fully active. Day 2, day 3, day 4, not fully active. So the person can still get the infection and can shed it. It is the trials have tested at least 2 weeks after the second dose, and from then on they are protected. Some have 28 days after the second dose, and some has 14 days, and Moderna has 14 days. So that means if you take any time before it, from a technical point of view, all bets are off from the first dose to the second dose. So first dose here, second dose here, first, second, and then 14 days after, 14 days. Till this time, the person can catch it and shed it. After this time, I'm just looking at the data. The time window may vary per person, but after this time, ideally, we have immunoglobulins, especially IgA, and that should block, as I mentioned. So this is the answer, that ideally the shedding should not occur once active immunity has become produced. Then there is the Vic-RV. Do you suggest that patients start daily aspirin in early stage after diagnosis and for post-exposure prophylaxis? So this morning I was speaking with someone. If their age is such or comorbidities are such that they are at a risk of cytokine storm, then they should start it. But you know that there can be bleeding disorders. So we have to be careful to see what would happen. Are they already taking some kind of anticoagulants? If we add aspirin, that can actually cause an issue. Do they already have some kind of a bleeding disorder, and so on? So if we're talking about a healthy person who may have some healthy in terms of bleeding disorders, who may have some comorbidities or advanced age, they can actually use aspirin from the beginning. Others, no. Youngsters, no. The second question is, what is the latest on reinfection time? Today, I heard of someone reinfected 2.5 months after the first infection. Are you seeing reinfections more now? If this is the case, can herd immunity ever be achieved? So very good question. And I did some research on that as well. From my own experience, so of course, my experience is limited. Now, I believe 400 patients. So I haven't seen reinfection in these patients. I have seen long hauling in these patients, where a month or so later, they are displaying the symptoms once more. So I have seen long hauling, but not reinfection. However, reinfection is a phenomena that is being seen, and I'm using the more flexible term of reinfection. Reinfection technically simply means that the virus arrives in our body once more. That's fine. It can arrive in everyone who has recovered or not recovered. Causing the disease again, causing the symptoms again, is the flexible term for reinfection. So causing symptoms again is being reported. I have not seen it. So from that reporting point of view, I wanted to once again show you this thing, and this actually makes me angry. This is, guess who? This is CDC. It actually makes me, I'm generally angry today because of the news. And then these are the guys. Whenever I go to their site, CDCs and FDAs, they are always found doing this, that, oh, we do not know. We are still collecting data. We are still doing studies. We're still waiting for others to tell us. They have no clue they cannot tell the difference of their elbow from their something else. So if I go in here, CDC says, just look at it. It is so angering. In general, reinfection means a person was infected, got sick once, recovered, and then later became infected again. Based on what we know from similar viruses, some reinfections are expected. We are still learning more about COVID-19. Ongoing studies will help us understand. Have they ever said anything better than this? For pregnant women, same answer. For reinfection, same. This has been happening since March, April timeframe. They looked at WHO, and them were informed of reinfections in Japan in March timeframe. And since then, they are saying, we are waiting for the data and the studies. We have studies. So this is CDC. I just wanted to show you for their incompetence and their lack of professionalism, I guess. So here is another site. This is the, excuse me. So this is actually Oxford University Hospital. They have done a study for the reinfection. So what they did was, and this, I love this part, what they did was they looked at the patients, not the patients, their own medical staff, and they just kept measuring their antibodies, and they kept measuring them for active disease. That means they did RT-PCRs on them for the active disease or the presence of the virus in the oropharyngeal area, and then they did antibodies on them as well. And here is what they found. They found out in this study, 89 of 11,052, 89 of them were without antibodies and developed a new infection with symptoms. So 11,000 doctors and nurses, 89 during this tenure of the study, window of time of the study, 89 developed infection. None of the 1,246 staff with antibodies. So there were 1,246 who actually had the antibodies when they started this study. That means they had developed the infection at some point and they had recovered, and now they had antibodies. So none of them with antibodies developed a symptomatic infection. So what were they trying to figure out? They were trying to figure out, here is a person who has antibodies, will he become sick again? And here is a person who does not have antibodies, and will he or she become sick? So they saw that the people who didn't have antibodies did develop symptoms and the infection. On the other hand, those that did not have the antibodies, that did have the antibodies, they did not develop the symptoms. Some of them, 3 of them. So out of these 1,246, so I think you can see the percentage from here. Out of 1,246, three actually were tested positive again. Now, why were they tested positive? It is possible that the virus arrived in their throat and in their nose, and it actually tried to increase there, and they had the antibodies, IgAs, I just talked about it, and they had the other immunoglobulins, and they had the B cells and the cytotoxic T cells, and they kind of took care of it right here. So maybe virus increased in number a little bit, but they never developed symptoms. They only had the positive PCR. Now, is that because a PCR was done incorrectly? Or is that because they were actually positive? Is that just because they had some sub levels of the coronavirus present here? Don't know. I have to look at the data to know more. But important thing here is, out of 1246, there were 3 who did become reinfected, but they didn't have the symptoms. So how were they then caught? How did we know them? We knew them because we continued to do the testing on them. If we were not doing the testing, they would have been missed. On the other hand, we also have the reports of reinfection where the reinfected person actually had greater symptoms, more severer symptoms. And we also have reports of reinfection where they had mild symptoms. So that means even reinfection, number one, it is rare, it is less, we shouldn't be too worried about it. But at the same time, reinfection shows the whole spectrum as well. Asymptomatic are more, then mild and severe are also present. So that is the thing with the reinfection. But please keep it in the context that out of 40-50 million cases, the reinfections are a smaller number. Now the right question is, why the reinfection? Is it going to happen to me if I get it today or not? So the cause for reinfection is still to be figured out. But the possibilities are, let's say a person's immune system is not responding correctly. That is one possibility. Another possibility is the person is actually immunocompromised, either artificially or genetically or by birth. Or maybe the virus has mutated, which is a less possible thing, but I want to list out all the possibilities. Maybe the virus has mutated and now it has a different way of presenting its antigens and our antibodies cannot catch it. Then maybe that the person only has the enough load. Let's say they're a doctor and they're exposed to a corona ward and they have a huge amount of virus going into their mouth. And then you take a swab and you just pick up those viruses that are sitting there, but these are not really going to be able to affect them because they are actually protected. So these are some possibilities. There may be more. So that is about the reinfection. I love this study and I'll talk more about it when I have the data. Then there's a cool bean from India who had sent me this link about the reinfection as well. And they are saying that there is a panic in Delhi that there are lots of reinfections. When I see here, as much as this is an interesting article, there are a couple of examples of reinfections. For example, here, so this is a person who became reinfected. I think she was a doctor after 2 months. Then here is one more person who became reinfected, but I do not see a data to say, well, there were 10,000 doctors and out of them 2 were reinfected, or there were 10,000 out of them 100 were reinfected. So without that data, it is difficult for me to contextualize that. But this means that they are also observing it. So that is the discussion so far on the Twitter side. I'm going to come back to the live side now. So let's see here, just one more. Can you explain if, when, how a false positive rapid antigen test can occur? Have you encountered any situation? So Vic, very good question. I have encountered mostly negative. Actually, I have seen the positive as well. All right, so let me give you my examples for both of them. A patient, recent patient, him and his wife, they both became COVID positive. From a clinical point of view, they both got the RT-PCR done. Wife came back positive. Husband came back negative while husband developed the symptoms first and then wife developed the symptoms. I requested them to do the PCR again and that came back negative again for husband. I requested them to do it once more and it came back negative once more, so 3 times. On the other hand, the clinical symptoms were of COVID. Wife developed COVID a couple of days later and she was actually positive. CT scan of the chest for the husband was also positive. There were changes that are relevant and that are corresponding to COVID. So this is a case where there were false negatives. Then I had a patient who was a doctor. He was actually working in an ICU or a corona ward. He himself became ill with it. They took him in a quarantine. He started being there. And then he ceased to have the symptoms in about 15, 16 days. Young man, so he became okay. But his RT-PCR kept coming up positive a month till another 30 days. And he became so frustrated because they would not let him go from quarantine because his RT-PCR would just continue to come back positive. So I had to send a message to his doctors to say that, guys, he clinically looks okay. Why don't you check his antibodies? If he does have antibodies, then ideally RT-PCR, there is a problem with the kit. Maybe there is still some virus hanging out there, but that is an example of false positive, in my opinion. His antibodies are present. So to answer your question, Vic, I have seen both, yes. What is the reason for this? More probable reason is the problem with the test kit itself. Then is the collection method. Then is the number of cycles used, that you take a very tiny fragment and just keep amplifying it so many times that you bring it above the threshold of telling the positive, and even a tiny fragment of the virus which would not create enough load to cause the infection is still going to come back as positive. Then I have done this discussion in detail in a lecture called, the title is Positive Predictive Value and Negative Predictive Value. And that is the prevalence of the disease within the society. So all of those things come back together to then decide if the kit will work correctly or not. So I would request, Vic, that if you can watch the positive predictive value and negative predictive value, and then we can have another discussion. So now I'm going to come back here on the live side. How are you guys doing here? I have not even looked at the talk so far. So let's see. And welcome to everyone. So let's see questions. Tim says, Florida mandated reporting PCR CT. What will this mean and show us? So this is a very important one. Cycle threshold is the number of times you amplify the RNA or whatever genetic material you are amplifying. There is a debate going on. Some scientists say that the basic initial load should be, if it is small, then it is not sufficient enough to cause a problem, and we should not consider that to be positive and not start quarantining the person. So what they recommended is to reduce the cycle threshold so we do not pile up the copies of the initial dose, and we do not say it is a large number. So some people say 34, 35 times amplification. The standard amplification at this time that is happening is 40. And I always wanted that the test should have the CT with it, the cycle threshold with it, so that the doctor can also decide that how much sensitive this test may be. So that is what it means. It gives some more clue to the doctor to see if the cycle threshold is too high, and then to see if the positivity that is appearing, does it have enough beginning load that it could be dangerous for the person or not. The additional thing now that should start becoming available is that what is the load of the virus that can cause infection or cause infection is presence of the virus that can cause disease. I think that study is still not done. This is a very good question. James Kelly says, Dear Mobeen, know that you're not alone in our extreme anger against health and government authorities that have shown gross incompetence and telling people to simply stay home. And this is, James, this part, just telling people to stay home and just isolate, that is a dangerous thing, because we are allowing a person to go through from a healthy state to a state where getting them back becomes an issue. People are dying at home, correct. No one tells them to check their oxygen saturation. No one telling them about vitamin D, C, and zinc, and absolutely no mention of ivermectin. When to come to hospital and when to, absolutely no mention. There is, I thought, James, truly, I'm telling you sincerely, maybe I'm naive, maybe I'm just too silly. I thought on the Facebooks and the Twitters and the YouTubes and the TV, there will be health authorities telling people, guys, take vitamin Ds and take vitamin Cs, and hydroxy could be useful and ivermectin could be useful, and stay home and isolate yourself with following things and have an oximeter available for you. I thought they would do those things. And this is a deafening silence on their end where people can be protected. Once people reach a point of they're in the jaws of death, that is when they start saying, all right, we're going to give you remdesivir and we're going to give you dexamethasone. And it is really bad. I'm just trying to see if there are any more questions here. So Jason Mateos, question: at what temperature are viruses deactivated? Is a sauna at 100 degree Fahrenheit safe? Very good question. The coronavirus has been, remember we say human coronavirus versus animal coronavirus. Human coronavirus normally tries to replicate or can increase in number. I use the term correctly because replication or division is not for viruses. So increase in number at cooler temperatures. So that is why human coronaviruses like to stay here, and they only cause upper respiratory tract infections. They do not descend down because the temperature is higher there and they cannot easily assemble themselves there. So I won't call it deactivation, but they cannot function at higher temperature. On the other hand, SARS-CoV-2, which is an animal virus, it has learned, or it was that way in the animals, that it can actually replicate or increase in number at higher temperatures, but still within our body's temperature limits. The study is that 56 degree centigrade for 15 minutes on a surface, that means direct exposure of the virus, will kill the virus. So I'm not talking about the ultraviolet rays, I'm talking about the heat itself. 56 degrees centigrades for 15 minutes can inactivate the coronavirus, SARS-CoV-2. The problem with the sauna or taking steam, and I still get so much heat, no pun intended, for my steam lecture, because people still keep getting it wrong, that they think I somehow I'm advocating that you should not take steam. Instead, what I was saying is that the virus that is present inside the cell, steam cannot help kill that virus, because virus needs 56 degree and the cell would die at 41 degrees centigrade. So let's say if I take a heater of some sort, let's say hair dryer, and I point it towards my mouth and I turn the heat up and bring the hot air in my mouth, before that hot air can kill the virus inside a cell, it's going to kill the cell itself. Now, if we burn the respiratory membranes, that can cause acute respiratory distress syndrome and can kill the person. This is what I had said, for which people still curse and yell at me that you are wrong, steam is very useful. So steam is useful, but just be careful. When you say 180 degree Fahrenheit sauna, it is fine. That virus that is on the surface of the sauna, or that is maybe early part of mouth and nose, that the one that is outside the cells may become deactivated. Depends if the heat, what was the temperature in these areas, but not in the rest of the body. And please remember, our body is very, very clever to be able to maintain its temperature. Because if the temperature actually goes so high that our body cannot modulate and balance it out, we would die. So it would not help a lot. So there's a lot of discussion that has happened here. And thank you very much for the super chats. Appreciate it. That is correct. CDC is a joke. Yes. At this time, I used to respect them a little more than now. Yeah. That's correct. They collect a paycheck. That's what they're doing. All right. I'm looking for questions. E-Dog, thank you very much for the super chat as well. So yeah, honey, the amount of honey used in the study that I shared, that was for the severe cases. For prophylaxis, smaller amount. For example, the honey that I have been using is 1 spoon of honey daily. So that may not be sufficient, but a smaller amount. And then again, please check for your diabetes and other cases that honey should not cause issues. So John Hansen says, Dr. Bean, my wife and I are using hydroxychloroquine, ivermectin, and quercetin together. All are at reasonable dosages. We are having no side effects. What are your thoughts? So you don't have a side effect, so that is good. And I have used hydroxy, zinc, quercetin, and ivermectin together for my patients as well. And I have not seen in therapeutic doses, I have not seen any issues. I usually do not use ivermectin at 200 microgram per kilogram. I use ivermectin at 150 microgram per kilogram body weight. So I use it a little lesser, but then I use it more frequently. So that is good if you don't have any symptoms. These should be safe in general. Cindy, would colostrum with IgA be useful to increase the IgA levels and offer some protection? Very good question, and I wanted to make sure that I explain this one as well, and thank you for asking this question, because I should have put that with the pregnant and breastfeeding mothers lecture. One thing that is important is that the breast milk is ingested, and then it has to be digested in the stomach and the intestine, and then absorbed. So our body can actually break down some of these proteins. So mothers conveying of antibodies to child through placenta is a very stable route. Mother's antibodies through milk, they would get digested and broken down by the acids and other digestive mechanisms before they can successfully be taken. So it is not necessary that higher levels can be achieved by giving oral antibodies. And in the breast milk, the antibodies are oral antibodies. The second thing is IgA is present in the milk. If they get absorbed in the blood of our body, let's say, they would not be able to be of much help, because inside the body, IgAs don't do much. IgAs do much on the surfaces. So when they are coating our GIT layers, and if there is any virus in there and the milk has IgA, it can help clean that GIT surfaces, but not inside the body. Zelina Arjun says, your knowledge, sir, is really amazing. My own primary care givers don't know as much. Thank you very much. I think it is the responsibility of all of us at this time, all doctors, healthcare professionals, to educate themselves so that they can protect their patients better. Simple Garden, I'm actually going to set up Patreon tomorrow, so I would attach that as well. So thank you very much for your wish, and we would do it. France says, yes, Dr. Bean, that is the right question. Why the reinfection? Correct. That is the important question before we talk about, okay, who has a reinfection, what is the rate of reinfection, and so on. We got to figure out why reinfection is happening. Is it a problem with the test kits, or is it a problem with the person's immune system, or is it a problem with the viral load that we are ignoring? what is it that is happening. So the person who is reinfected, we should not just say this person got reinfected as well. We should actually look more closely and take some of their cells and maybe swabs, and then check what is their genetic predisposition, what is their body's situation, and so on. We need to study that. But here's the deal, France. We have failed to study long haulers, who are a lot now. I I doubt that they would do decent studies on reinfections, which are much, much more rare. I think if there is a priority at this time, that is to protect people in the early stages with prophylaxis and early stage of the disease. And the second priority, or equal priority, is long haulers. They are going through a lot of, it's terrible to be a long hauler. The neurological symptoms, the tiredness, the fatigue, the depression, the inability to work, the continuous fluctuation of the fevers and the cough and the body aches, it is a huge problem. Some people have GIT issues. We just keep coming and going. Some people have cough that doesn't go. Maybe I'm a long hauler. So, so that has to be done as well. Kurt says, I have two friends reinfected, one with lesser symptom and a long hauler with worse symptoms. Yeah. Marie, so that is the problem. It's not necessary that always it is more severe. There are so many reinfections happening that are not even symptomatic. The only thing is, once somebody is severe, we find out. Cindy says reinfection would be more severe if the person had a full antibody response, right? If we have the correct, instead of saying full, I would say correct. If we have the correct balanced response, then there should be no issue. It is the dysregulation that causes the issue, and we're seeing that with the COVID, there can be dysregulation. Why is the dysregulation happening? You've seen many genetic markers and others that there are some people who are predisposed to it. The question is that the first time the person was not dysregulated. Why did they get dysregulated the next time? Is it the dose dependent, or is it the immune system that was already there just went mad the next time? Normally, what we are seeing is that if somebody has a propensity for dysregulation, then they become dysregulated the first time and the second time. But there are people who have less symptoms first and then more later on. Still need to figure it out. Bergerin says, is there any reason not to open up everything after the vulnerable have been vaccinated? So if the vulnerable have been vaccinated, then no, everything should become opened up. There should not be an issue with that. Shahida says, question, shouldn't supplements help long haulers? Yes, but what I'm seeing is, I think it also depends upon what is causing the long hauling. Fish oil, statins, of course, vitamin D and C and those levels should be correct. And then CoQ10 and ivermectin can help. For me, till today, the best management has been steroids. But I've read comments here where people have said that, hey, I am a long hauler and I had 2 or 3 pulses and I still did not recover. So there is something more happening as well in some people, and that need to be looked at. So 1x2 says, question, in UK, it's 3 in the morning. Doctor, could you do a Q&A when more people are awake? Good question. Please comment for what time would you like, or maybe I can do it twice, once at this time and once later in the day or early in the day. So please comment. Depending upon the audience here, we will know how many people need a different time as well. So maybe I can do it 2 times. Arsalan says, Assalamu alaikum, sir. Why stroke is more common of this virus? I think the question is why stroke occurs because of this virus. And most of the other viruses don't do it. And I have done this discussion before. The reason for that is hypercoagulability. So this virus can cause vascular damage. And that would be true for anything that causes vascular damage. When the vascular damage occurs, then the coagulation starts occurring. And that coagulation causes the thrombi and emboli to be formed, small pieces of clots in our blood vessels. These clots can actually go and get stuck in the brain blood vessels and cause strokes and other such issues. Anthony says long haulers will be left in the dust once vaccine comes out. I think that, Anthony, there will still be people, I would probably put myself in that category as well, who would switch from the main education systems and then start looking at long haulers. So I think the attention would reduce. It is already less, but there will be more focus on long haulers as well, because it is a problem and it needs to be solved. So I am missing more questions here, so I'm going to go to the Twitter for a few more questions here. So the Kraken Mega has a link here. Thank you, Kraken. Dave Gravina, do you also feel the chemical-laden hand sanitizers, bleach, and industrial disinfectants will have a negative impact on our health, perhaps worse than COVID long-term? I know that the subtext of this question probably is that we would kill good bacteria or viruses as well. I don't think that and then probably another subtext is that there are chemicals in these things that are going to hurt us. So again, as long as the quality of the content is good, these things are good, sanitization should not cause damage. The repeated use of antibiotics can cause an issue. Repeated use of clearing the normal flora of our body can be an issue, but not with the sanitizers. Bleach should, of course, not be used other than the surfaces. And disinfectants are fine as well. They're for surfaces too. So I don't see a huge issue there. Yes, misuse should not be. Zubair says, question, what could be the underlying cause in patients with reinfection, and will they require more doses of vaccine, or that are not likely to benefit from vaccines at all? Very good question. So we have talked about the long hauler, reinfection many times. I just talked about it as well. Reinfection because the person never recovered, was still a carrier. Reinfection because the testing was wrong, either first time or the second time. Reinfection because the person actually had the virus in their throat and we picked it up, but that virus was not going to do anything because their immune system is now trained. Reinfection because their immune system is not trained. It does have a problem, and that problem may be genetic. That problem may be acquired, for example, HIV. That problem may be by medicines, for example, immunosuppressants for cancers and so on, or immunosuppressants for autoimmune diseases. So it really depends what is the cause of reinfection before we can say what should be the solution to that and should they take vaccines or not. So I think the discussion should be, here are the categories of the patients with reinfections, and here is the prescription for each one of them. This person can have vaccine, this should not. For example, somebody with a persistent virus, maybe they can have vaccine, but the virus is present in them and not triggering their immune system. What will vaccine do? Then let's say maybe a person is reinfected because they're immunosuppressed. Then the vaccine is also going to trigger the same immune system which is suppressed, and they can get the reinfection, and so on. So I think we have to address vaccines question to each category separately. J.S. McClellan says, ivermectin promotes peripheral nerve regeneration. It also inhibits inflammatory cytokines seen with post-COVID, including TBF-alpha and IL-6 in mice. So very good. I have that open here. So they say ivermectin confirms its cytotoxic effects by inducing AMPK and mTOR-mediated autophagy and DNA damage. So what is happening here is that ivermectin in this study, they say, can cause cell damage. The thing that was missing in here for me is that everything can cause cell damage. Every drug is a poison if it is given outside of the therapeutic dose. So ivermectin can do that too. Every drug can do that. Question is, what was the dose in which they used it? Was it outside the therapeutic dose, or did they see this effect within the therapeutic dose? And the cells that they used it on were the human cells or others. We know that worm cell and other such cells are affected by ivermectin. Human cells are usually not affected by ivermectin. That is why we can use this drug. So the dosage and those things have to be looked at. I did not open up their PDF. I don't know if they had the PDF here. Maybe there is more data in there, but this needs more discussion. Ivermectin is pretty safe in the therapeutic doses. This one I loved. So here we have Robert Huffman, and he says, any other studies on Nigella sativa? I think there are a bunch of more studies, Robert. Would love to have your feedback on this little project if you have some time to look at it. I did look at it and I'm going to show it. I loved your project. Been loving your mechanism of action videos. Thank you very much. So let's look at the project. So there is a link here to a Google document, and here is that document here. So what Robert and team has done it is, I hope that this is Robert and team. If it is Rob alone, then awesome. What they've done is that they have put various things here: vitamin D, zinc, melatonin, vitamin C, omega, and so on. They put them there. Then they have created the phases of the virus and the disease COVID-19. And then they have said what thing is useful when. I love this chart. And then they have gone on to protocols and articles and sources. I wish that this was actually a website with all of this information there. So, excuse me. So if you see here, these are protocols. For example, Zelenko, Rau, Math plus IMAS, budesonide, and so on. These protocols are here. Then they have sources. So they have a very extensive list of references. And then how and why. They have these commentary as well. So Rob, good job. Thank you very much for sharing this. This link is present in the description as well. This link is in the Twitter thread too. And I had retweeted it today as well. So good job, Rob. Marie Guerrero, Dr. Bean, I found information online that NSC can raise your blood pressure. Do you know about it? I have been taking the supplement for more than 4 months, and I have noticed higher value in my blood pressure. So first of all, yes, it can cause higher blood pressure in some people. In some people, it is actually protective. So please adjust the dose that it does not do this to you. And if it still does it, then don't take it. Thank you. So very good question. And I have a link here that shows NSC. Where is it? So I had a link here that shows that NOC's function. I can't find it. Okay, so this is the one. So this is about the NAC. So if you see here, NAC fools the body into thinking that it has an oxygen shortage, said Dr. Ben Gaston, UVA Children's Hospital pediatrician and research who led the study. We found that an NAC product formed by red blood cells known as nitrosothiol bypasses the normal regulation of oxygen sensing. It tells the arteries in the lung to remodel, they become narrow, increasing the blood pressure in the lungs and causing the right side of the heart to swell. So this is what they say. They say pulmonary hypertension compared to the other. And I've seen the studies that say that it is protective as well. So just be careful if it is causing BP issues, and then stop it. Okay, so back here. Ulbeen 3381. Question 3. If a person is recovered and not shedding, can they still act as a fomite? So the first question, good question. First thing, fomite by definition are inanimate surfaces. So if I am shedding, I'm not a fomite. But if I have placed the virus on something, which when somebody else would touch and they can get the virus, that is a fomite. So with this, if I rephrase your question, if a person is recovered and not shedding, can they still act as a vehicle to spread? Yes. So for example, if my hand is dirty, I touched some place, that place had somebody else's snot on it or spit on it or virus from someone else. I touched it. Now I go and touch somebody else. I'm going to spread it. So can a person spread it? Yes. Vikram says, Dr. Sayed, a friend who is a long hauler in Dhaka may want to consult you. Vikram, please remind me. Either you send me a message or I'll try to remember and send you a message. Governor Key, I haven't seen a discussion on this issue. The issue is vaccines are coming soon. For those who are taking medications for antiviral properties, is there a concern that these could dampen or prevent the antibody development response to the mRNA vaccine? This is a very good question. The question is that if somebody is taking antiviral, that antiviral can stop, let's say, SARS-CoV-2 as well, in theory. If that is the case, then if we give a vaccine which is going to act like a virus as well, will that not be stopped by the antivirals we are taking? Answer is no. And here is why. Let me explain it. So what happens is, let's say this is our body. When we take antivirals, excuse me, act on the virus itself, correct? So they act on the viral enzyme, excuse me. So Avox on Twitter, you had asked me to keep the water with me. So here is water. Okay, so antivirals have to work on some part of the virus replication or virus activity. So either they do not allow a virus to enter the cell, that is one possibility, or when the virus is inside the cell, they do not let it uncoat or take its membrane off for the envelope virus, that is another. Or they can act on its enzymes, for example, RDRP, and suppress the enzyme from functioning. For example, zinc does that. Or they can cause the viral proteins that go to the DNA to cause the DNA to suppress itself and not kill the virus or not defend itself, like Ivermectin. Or they cause the virus to be built with the incorrect RNA pieces, or the bricks or the raw material is wrong. And so the virus is built, but that has fake bricks in it, and the virus is not a virus. All of those things are possible with antivirus. The case of, for example, mRNA vaccine, what would happen is mRNA goes into a cell and directly goes to the ribosome and gets translated into a protein. That protein is the virus's spike protein, and that protein is shown on the surface of the cell. So it bypasses all of this because it is not a virus. That is how, if you're taking antiviral, even then mRNA-like vaccines will work. On the other hand, let's talk about for example, Imperial College, the weakened attenuated virus, adenovirus. Even in that case, we are not expecting the virus to go into the cell and replicate or increase in numbers. We don't want that. That virus, the adenovirus, does not have the capability of... Hey, Lucy. What's going on? So the virus for example, adenovirus, does not have the capability to replicate or increase in number. So antivirus will not cause any issue to that as well. The virus itself, the adenovirus itself, contains the mRNA or the RNA in it. And once the virus is inside, it's just going to leave the RNA, which would go to the ribosome, and the ribosome will make antigens. So, short answer to your question is that no, antiviral drugs, if you're taking, will not cause the vaccine to become ineffective. Louis says, and after this, I'm going to come back to the live side. Being a long hauler, March case, I'm sorry, Louis, will like, if possible, to discuss and understand your current protocol to treat it so I can discuss with my doctor. God bless you, doctor. Thank you very much. And I'm sorry about this situation. Look at this. Fish oil, you can do at home. Statins is by prescription, at least in the US. Ivermectin is by prescription, and steroids are by prescription. My recommendation is to get the steroid dose first without anything else, and then see what happens. If that works, good. If not, then add ivermectin. If that doesn't work, then add statins. If that doesn't work, then add fish oil. That, I think, should take care of it. I usually do this, give one pulse of the steroids and then wait for 2-3 weeks. If that doesn't resolve the issue, then I give one more pulse, and normally with 2 pulses, people recover. Okay, so back here. Are you guys laughing about Luffy? He's now sitting here. So I think he wants to go to the other room and the door is closed. And he has learned to just make noise and then he gets his way. He's sitting here now. He's quiet. So yes, he's here. So Luffy is a male. And Kyrie is sitting right over there. And she is a female. Kyrie never talks. She is just sitting there and chilling, and that's fine. Luffy is sitting here now, but he was the one who was yelling. Yes, they were going crazy, correct. France says, quick check Twitter to see what Luffy is saying. Yes. Okay, so what other question here? Luffy's being... Do you know that this is... Jem, this is why we actually called him Luffy. So we thought when we got these two, Luffy and Kyrie, Luffy seemed so goofy. So from the goofy, we called him Luffy. But he is so naughty. So you actually got the root of his name. So 08 KLM says, do mRNA vaccines require adjuvants equals DNA vax? Can nano aluminum hydroxide adjuvant creates carcinogenic prions inside us? So 2 questions. The first answer, so far, the data that is coming from Moderna and from Pfizer, they say we do not need adjuvants. The normal role of an adjuvant is to kind of trigger the immune system at the site of the vaccination so that the immune system kind of works a little more. They say that the nanoparticles themselves can act as an adjuvant, so they do not need the regular standard adjuvants that they need. The lipid particles will be incorporated in the cell and they can act as an adjuvant for some of the immune cells. Now, the second question, can nano aluminum hydroxide adjuvant create carcinogenic prions inside us? So the prions are fragments of RNA. They are not even viruses. They're tiny RNA fragments, just tiny fragments. Can nano aluminum hydroxide cause production of prion? So here is what they would need to do. So the short answer is no. But if I think aloud with you to see what are the needs to create a prion, what will happen is some substance let's say aluminum hydroxide, something will have to work on some RNA. So let's say this is an RNA. Maybe this is our RNA or this is a viral RNA. And then it will have to remove a very tiny piece of this RNA, which is intelligent enough, that piece, to cause increase in number and cause some kind of immune response. So, excuse me. So, can aluminum do that? Not really. It cannot be so intelligent to go into an RNA and then decide that I'm going to cut this part of the RNA, and this part of RNA can live by itself and become a prion. So, very difficult thing to do. It would need a lot of engineering to actually create some kind of a substance which does it. He just got up and went. Siddhartha, I saw your message that love to see Luffy. When he comes back again, I'm going to try to catch him and show him to you. Okay, so what else questions? So mad aluminum cooking pot disease, underarm deodorant causes mad cow disease. So I will not comment on this. There are some things, metals can cause issues. Dip Doso says, hi, Dr. Bean, is there data on whether the vaccine prevents infection and infecting others? I do hear it prevents disease, but not sure on infection. Vaccine cannot stop infection. Infection simply mean virus arriving in us. So that vaccine cannot do. The interesting part of your question is it possible that because of the vaccine, I cannot get the disease because the virus cannot replicate or increase in numbers in large enough quantity and disrupt my immune system? But can it continue to replicate enough that it can then shed and go to the others? I'll give you the technical answer because I do not have the data from vaccinated people about this question. More technical, theoretical answer will be that because vaccination has caused the production of immunoglobulin A, and immunoglobulin A is going to be sitting in our mucous membranes, and when the virus arrives, immunoglobulin A is going to catch it. Virus will not have a chance to replicate in greater numbers, and because immunoglobulin A would have caught it, even if the virus is now with that immunoglobulin is shed out, it is going to be really difficult for that virus to get dissociated from immunoglobulin A and go into the other person's cell and cause replication. So I would think that it would not be shedding in terms of being able to go and infect someone else. Laura has a question. How much dexamethasone and how long? How much statin and which one? So I'll give you, dexamethasone is not the right answer for long hauler. I'll give you my protocol for my patients. I give them 5 milligram. So let me draw it here. I've done it a few times on Twitter as well. So delta Cortril, 5 milligram. And this is how I have been giving, and this has been working for me. And every doctor has a different way of tapering the steroids. So I will not argue with that. What I do is the first 2 days, day 1 and 2, I give it 3 times, 5 milligram, 5 milligram, 5 milligram. Same here on the second day. Then 3rd and 4th day, I only give it twice, but in the early times. So 5 milligram in the morning and 5 in the lunchtime, and skip the dinner. Then the next 2 days, 5 and 6, just 5 milligram in the morning and then done. This is what I do. There are doctors who give, let's say, 3 times for a full week, then 2 times for a full week, then 1 time for a full week. So there are various protocols for tapering. This is how I do it. For the statin, I will not give a dose here. Instead, I would ask to talk with your doctor to see what is the right dose and the right statin for you. because various statins have various doses. So lower dose statin, because we're not using it for cholesterol, basically, we're using it for anti-inflammatory. So lower dose statin can be fine. Kisu Rawal says, question, is vaccine safe for children under 2? Very good question. Vaccines are only tested on 18 plus. So they have no idea for lesser than 18. And I think the reason for that is that the people lesser than 18, they usually do not get infected, or if they are infected, they are asymptomatic and their death rate is very low. So I think they kind of excluded that community from vaccine. So Grant Glad, do you think reinfection is in long haulers who never developed antibodies is possible? Seeing anecdotal reports of it happening from other long haulers, also, do you think second infection will be worse? So as we had discussed before, most of the time reinfection is lesser in symptoms. Some people have worse as well. So that means we cannot generalize that it would be worse or not. The whole spectrum is available. The second part here, that the antibodies, there is a question here in the Twitter as well, which is on the same lines. Look, I'm going to draw this part as well. So we have been, Grant, we have been doing this discussion in the past that the way our immune system manages the infection is in some people right at the innate arm. Then in some people at the B cell side, humoral side, excuse me, and then in others in the cytotoxic side. Correct? Now imagine we have a person A. That person has, let's say it's a child, 10 years old, 9 years old. They would handle the virus 90% at their innate arm. And they would probably have no antibodies or no cytotoxic T cell, or even if there are these two present, antibodies or cytotoxic T cell, they would be really low in number. And we would actually think that these are not positive. That is because they have responded primarily through the innate arm. On the other hand, let's say we take another regular person, me, got the infection, 10% handled at the innate, 60% handled by the antibodies, and then remaining 30% with the cytotoxic T cell. In this person, you would see antibodies to be present, and you can test them and say this person is positive. Now imagine one more person who got the infection, 10% at the innate arm, 70% at the cytotoxic, and then 20% at the antibody. This person, when you test them for antibodies, will show almost negligible antibodies, but they have taken care of the infection. And what we are seeing is that if this is the pattern of the immune response, they have less symptoms or almost asymptomatic. If the pattern is the other way around, for example, this one, that they have 10% here and let's say 60% here and 30% here, this pattern has a possibility of immune dysregulation. So hope that answers excuse me, that question. Okay, so John Hansen, how is the Moderna vaccine different from Pfizer, and Moderna Meridian vaccine different from Pfizer? I have contacted about bringing in Meridian trial. Should I stop the prophylactic protocol to do the trial? I do not know about the Meridian vaccine. So can you send me some link so I can read about them? Excalibur says, should I stop taking Ivermectin a few days before getting COVID-19 vaccination shot? So let me explain that the short answer is no need to. Long answer is, and I had somebody else ask me this question as well, that if, sorry, that if we are taking ivermectin as a prophylaxis, would that make the vaccine ineffective? So look at this. Ivermectin's role is to prevent viral cargo to go into the cell. That is the role of ivermectin. So let's say ivermectin is present in our cell and we give a vaccine, and the vaccine has messenger RNA. Messenger RNA goes into our cell and talks with our ribosome, and the ribosome is now working on this messenger RNA and making proteins, these spike proteins. In this whole process, the ivermectin's role of stopping the virus cargo from going into the nucleus is irrelevant, because this messenger RNA is not making any viral cargo that needs to go into the DNA. So, excuse me. So even when you have ivermectin, and even when you're using it, it will not make the vaccine ineffective. So hopefully that answers that question. AD says, do you think aspirin will be available, will be a viable treatment for COVID? No, aspirin is not a treatment for COVID. Aspirin is a part of the treatment for COVID. When the patient starts getting blood hypercoagulability issues, that is when aspirin or other anticoagulants are useful. AG says, time to infection after exposure is said to be 2 to 14 days for COVID. Is there a correlation between the number of days and severity of illness and mortality? No. So the mean average is 5.1 days. There is a correlation with the viral load. There is a correlation with the person's genetic makeup and the immune response. There is a correlation with the vitamin D and C and other levels, but not correlation with the number of days. VM says, can we treat with 6 milligram 4 days instead of 12 milligram 2 days? My patients who have active disease, my problem is that most of the time, the patients who are referred to me, they have already become dysregulated or they are going downhill. And the local doctor have said, I don't know what else to do. And then they somehow find my number and contact me. So most of the time, they are becoming aggravated. So I usually give them 12 milligram in 2 doses, 6 milligram, 6 milligram, and I'll just continue for 4 or 5 days. The regular protocols that have been tested, this is my protocol, it is not tested protocol, it is just for me, and my observation is there that it works. The tested protocols are 6 milligram morning, evening, then on day 1, day 4, and then once every month in the same pattern. That is for prophylaxis. And for treatment also day 1 and 4, and that's it. There are some trials that have been done where only one stat dose of 12 milligram is given and done. I continue to give it for many days. Barbara Warren, lysine helps with viruses in general, limiting arginine protein synthesis. The lecture yesterday was great. Arginine, would lysine help prevent COVID-19? So not prevent, but these substances help reduce the virus's ability to cause damage. So they would not prevent altogether. I think for prevention, we still need, the right thing is to have the vaccine, for example, or mask and the social distancing. Excuse me. With that, the vitamin D and C and NSE and the CoQ10 and melatonin and other, so the whole cocktail has to be there. That still cannot rise up to the level of prevention. But what I'm seeing is that if somebody gets infected after that, one, they don't become long hauler. Second, they have lesser symptoms and they recover fast. Nabu has a question. Nabu, we've missed you. You have not been here for some time. Have we talked about the aberrant STAT3 pathway? Ivermectin inhibits STAT3. We have talked about JAK-STAT pathway as well. Yes, in one of the previous, I think, recent talks. So let me answer some of the Twitter questions as well. So continuing on here, Roshan says a recent study suggests that ivermectin can damage the DNA. So this is the study that I showed here. And again, the question is that DNA damage, what is the dose, and so on. So I think I should have shown this at this time. F. Bolito says, thank you for your great work. My wife, and son did an antibody test for COVID-19. The lab uses Roche Elxis test. The baseline for IgG is 10. My wife got a 39, so she has the immunoglobulins. Myself, 2, my son, 6, both with no antibodies. How is this possible? We live all together with no isolation. Two answers for this. One answer is the one that we just talked about here, and that is this. It is possible that you and your son has actually, if I remove this and say 10% response here, let's say your son actually had 80% response here, 10% here, and 10% here. So then he would show very low antibody levels. On the other hand, let's say you had the response in this way. You had 10% here at the innate arm, 70% here at the cytotoxic arm, and 20% here on the antibody arm. If that is the case, you will also have low antibodies, but you would have taken care of the virus easily. And the people who take care of the virus in this arm, they usually are asymptomatic. So for your son, it makes sense as well. If he has taken care of the virus at the innate arm, he would not have much symptoms. If you have taken care of the virus with the cytotoxic arm, you will not have much symptoms either. So that is one answer. The second answer is, the second possibility is that you actually had, let's say at some point you became infected and you had the virus in you. So let's say that is day 0. Now within 5 days to 14 days, the antibodies started getting produced, IgM and IgG. Then what happens is these antibodies start declining if there is no more virus. And so the antibody levels have now dropped and they have gone to baseline. If we expose someone like this to the virus again, then these sleeping B cells are going to wake up and start making antibodies again. So it depends, when did you get the test done? How far was that test from the day you became infected? And it also depends upon how did your immune system actually respond. So these are the reasons where you may have actually low antibodies, but still have the defense capability. Couple of more questions, and then I'll come back to life. So Scott Robinson says, is the CDC delay reasonable compared to the UK vaccine rollout? Scott, this is such a weird thing that UK has rolled it out. They had, Pfizer had applied on November 20th or something like that. I discussed it a couple of days ago, and the date is 10 December. Similarly, Moderna applied on this 31st November or something like that, and they have a date for 20th December. So I was reading the news where, of course, Trump had said that, hey guys, why are you taking so much time? He wants to take credit for it. He wants to get it done earlier. But forgetting about the political part of it, the question is, why so much delay? And they responded and they said, we need our scientists to go over the data and make sure that they have analyzed it. And guys, this is a pandemic. Work 24 hours a day. Find 20 more people to work with you and spend your days and nights to crunch the data and figure it out. Don't work in 9 to 5. And I know that even in 9 to 5, you're sleeping majority of the time. Maybe you're just working half an hour after the breakfast. So stop doing that. Spend more time. Hire more people. You have money. This is your duty. So they are not behaving as if there is an emergency. That is what is really upsetting. So Scott, um, I do not know what is really the reason, but whatever the reason is, in the whole world at this time, other than pandemic, there is nothing else that is important. So they should find a way to accelerate it. Dallas says, Scott, I was thinking the same thing. Why are they waiting until the 10th to meet? Why can't they meet today? Correct. So they say that our researchers and scientists have to go over the data and it takes time. Go find more researchers and scientists. Norman Kelly says, Dr. Bean, great interview with Dr. Merrick. I've started the IMAS Plus protocol, but need Ivermectin. That is the primary thing. I missed your link last Friday for a company that may prescribe with appropriate health information. So Norman, I have sent you a message in which I put their link. So I have no association with them. The link is Speak with an MD. I don't have any association. I have no affiliation of any type. They had tweeted to me that we can look at a person and then decide if we should give ivermectin or not, and we would decide, but we are open to it. So if somebody wants it, you can use that. Green Dot has said something which I would just scroll beyond that. Okay. So here, Daniel says, please check these powerful data suggesting L-Lysine as an important tool for the treatment of COVID-19. So I actually have that open here. Thank you, Daniel. So here they're saying L-Lysine, it's an amino acid, I believe. They have been in Dominican Republic. They have been giving 2 grams per day of lysine with the required, excuse me, I'm so sorry, with the required dietary restrictions. So I got to tell you something about my cough. The whole day I do not cough or cough. It is when the lecture time arrives, I start coughing. So my wife thinks it is psychosomatic. I think it is cats. I have an allergy since the smoke and the fires. I think I've developed some immune dysregulation that I react to the cat's hair now. So during the day, I keep accumulating those allergens, and by this time I start coughing. But the whole day I'm fine, actually. So here, L-Lysine. So they had given in Dominican Republic 2 grams per day of lysine with the required dietary restriction. And after 3 months, through the spring to summer peak of COVID-19 cases in the Dominican Republic, with daily face-to-face exposure to SARS-CoV-2 patient, not a single doctor, nurse, or staff member fell ill or tested positive. And the number of people were 30 medical professionals. So small set. So they say that it is very useful. So Daniel, thank you very much for sending it. Some more data here for lysine. Bodia Cornell. Dr. Mobeen, can you tell me, please, why in India health workers are given 2 tablets of hydroxychloroquine per week for 8 weeks? Is it enough for a whole year preventively due to the half-life of SCQ? I saw that low-risk people are given only 3 weeks. So the half-life, which I knew, was 30 days or so. Half-life that I heard from Dr. Merrick was more than that. Still, when you accumulate the hydroxychloroquine for once a week for 8 weeks, it is not sufficient to protect for the whole year. I usually give weekly, but please realize it can cause arrhythmias. I was talking with a doctor this morning who I think is a cardiologist, and he was talking about his patients and he was thinking about giving them ivermectin or hydroxy. And he was asking me what is my experience. And I had said to him was that in my whole experience, about 250 patients with hydroxychloroquine, there was one family, 5 members, father, mother, 2 daughters, and a son. They all became ill together. I gave them hydroxychloroquine, and I believe that children, all of them, developed arrhythmias. All of them, children, and parents stayed fine. And that really made me nervous because I worked remotely. And so every time they'll have arrhythmia, they'll call me and I would have to say, please go to emergency. And that was scary. Nobody else. So since then, I've started using ivermectin, and I do not see these things with ivermectin. So I lean towards using ivermectin more. So to answer your question again, I think this is just their initial way of working with hydroxychloroquine. Ideally, for healthcare workers or essential workers, hydroxychloroquine prophylaxis should be longer or should be replaced with ivermectin prophylaxis. The 3 weeks for the people who are attending, I had actually discussed this protocol here with Cool Beans. 3 weeks with the attendees, the point is that during that time, if they don't catch the infection, then they're fine and they will not catch the infection, at least in the home. Cindy, can NKC, so natural killer cell, transfusion be a useful therapy for COVID-19? So I have it open here. First cell treatment to fight the coronavirus awaits FDA approval. And I think you may have actually heard this. We had, Cindy, in the very early part, I believe it was March, April, we talked about natural killer cells, and I actually referred to them as well. I did not know their name. Natural killer cell therapy can be very useful because we saw the difference between the adults and children is more robust and more in number natural killer cells in children compared to adults. So yes, more natural killer cells are very helpful for COVID-19 protection. However, these guys are still waiting as well. I know that they had gone on to various TV programs and so on, but FDA is FDA and CDC is CDC. If they are not going to look at you, they're not going to look at you. They would look at Pfizer and Eli Lilly and Johnson and Johnson's and bigger fish. They're not going to. It is unfortunate, but this is what I've learned. They don't care for it. They're not looking at things to be discovered from a patient's point of view. They're looking at the things to be discovered from their contacts and connections and their own influences point of view. So Cindy, we talked about them. So let me go here to the live side for a second. How are things here? Bart, do you feel it's safe to take? So William Goff says, do you feel it is safe to take ivermectin for prophylaxis, 150 microgram per kilogram per week, and also get the vaccine? Will there be any interaction? So I have been giving prophylaxis of ivermectin this way to the people I know. So far, there has not been any issue, but this has never been used like this. So the therapeutic doses of 150 microgram per kilogram is actually given usually once in 3 months or once in 6 months or once in a year. So the repeated doses are not given. The half-life is 18 hours. So that means the dose will become half within 18 hours, then half of the half within another 18 hours. So by 1 week, majority of that would have actually gotten out. So you can then give one more dose as well. So in my opinion, it is safe, but there is no study for this. So Moroccan man says, hello, doctor. Great work. I'm worried when the vaccine, Sinovac vaccine from China is going to be used in Morocco. You're worried that it is not used, or you're worried that it will be used? I am still waiting on Sinovac's data. They keep saying that we have data and we'll be publishing it soon. I am still waiting for it. As soon as they publish the data, I will do a talk about it. So Shahida has a comment here. I have been taking things for cough as well. It's funny that the whole day I'm fine, so all of a sudden it just starts. Um, So Jem says, what I meant to say is that third world countries are doing much, much better than the US. And in my opinion, that says everything about pharma in the US. I had done a talk, Jem, in which we made a little cute cotton ball and a kitten who had the cotton all over themselves, the strings. In the US, we have put ourselves so much in the red tape and become so used to normal, regular, lazy way of working for these things in more regulated way that we did not become active with the pandemic as we should be. The emerging markets, they never had that strict control, and then they actually became it became good for them at this time because they were able to. When I sometimes prescribe in some other countries, people can just go to the pharmacy and get ivermectin over the counter and or delta cortril over the counter, and here we are stuck that it is an issue. Seems like there is not. Okay. So there is a question by Nabhu. Question: if Pfizer and Moderna are mRNA vaccines, why their storage temperatures are very different? Very good question. So the first question I think should be, why do we need such cold temperature for Pfizer? So let me explain that. And then your second part, let me give you the answer for that first. They actually asked Moderna that why do you not have that such ultra cold temperature requirements? And Moderna said that we have done our testing and our technology is superior and our intellectual property is such that we know we don't need it. And so we're not going to tell you exactly why, but we don't need it. So here is what's happening. Why do they need such low temperatures? The vaccine has antibodies in, sorry, I'm making antibodies. Vaccine has messenger RNA pieces in it, correct? These messenger RNA pieces are very delicate for temperature. Imagine we cook meat, correct? These are very, very microscopic, tiny pieces of meat. Meat is cells with DNA and nucleus and everything and RNAs. At very low temperature, even at a low temperature, they very easily break apart. So they decay. Like if you put a chocolate out on the table in the sun or in the hot temperature, it just melts away. So their their content is broken down very easily. So this is why they need to keep them cool. And it turns out that they have to keep them so cold that it has to be, for example, minus 94 degree Fahrenheit or minus 70 degrees Celsius for Pfizer. Now, Moderna is much less needy for this cold temperature. They say that we can be in the normal room, not room, refrigerator temperature. So they were asked this question that why are you able to be fine with refrigeration and Pfizer is so needy? And they said, this is how our technology is. So that means I do not have the technical answer. So you also don't have the technical answer yet. Maybe we'll know more later on. So Jim, that is the fun thing. One thing that I have seen is that every time I take my supplements, I start coughing after that. So it looks like there is something in the supplements that irritates me. And I take 20,000 international units of vitamin D daily. David, question, what is the milligram dose of ivermectin in nasal spray? I do not know this one. because the nasal spray ivermectin is something that is here. What I do not know is that necessary for the absorption, or is that just for the protection here in the nasal area? If it is for absorption, we still will have to need 12 milligram per day, or 150 microgram per kilogram per day, whichever way it gets absorbed and becomes that way. Bob, maybe it is a reflux. So I do not have reflux. So that is also a very good point. I do not have reflux. This started when there were fires and smoke, and it has now tapered off, but not fully gone. And by the way, I don't like to take too many lozenges. They just make me so numb there. So maybe I should take more lozenges before. So Bob, thank you very much. Yes, so Dr. Marek had sent me the note to say, hey, we're going to be doing a press conference. I haven't heard their press conference yet, but I'm going to hear it. I think that they did a great job, and they're awesome. So 1x2 about the BBC and ivermectin. I do not know why the ivermectin is not easily talked about. It should not be a taboo. So what happened in the US was hydroxychloroquine was spoken by Trump, and then the whole world became upset about it, and then it became a taboo. For ivermectin, it should not be this way, but still the medical community is just going ignorant about it. Okay, so I'm going to go to Twitter. Nipa Gandhi, that is a good idea. I should keep cloves in my mouth. And Siddhartha, so thank you very much. I think it is from the lack of fresh air because we're all indoors. Possible, yes. So let's look at the Twitter for some more as well. Hello Sunny says, ivermectin and melatonin are not available in many EU countries where I live, unfortunately. But bromhexin and ambroxo are OTC. Can you make comparison among TMPRSS2 inhibitors drugs towards COVID? So I know that the study that we talked about, hello Sunny, in that they said ambroxol worked better than bromhexin. I think they are, only my opinion, options beside D and zinc. So ambroxo had performed better than bromhexin. Max Rosenblum, I've seen a couple of studies linking mindfulness and meditation practices to reduction of IL-6. What's the latest science around this and areas of research worth pursuing? So I had done a talk about the a few months ago. Luffy's back. Luffy, what's up? Come here. So I had done a talk a couple of months ago about this exact point. What happens is that somehow the Luffy, stop it, Luffy. The phytochemicals that are present in the plants and the restfulness and the relaxation of our mind improves the functioning of natural killer cells, which in turn allows our immune system to react better. That is the basic science. So if the natural killer cells are working better, then we are modulated well, our immune system, and so it does not become dysregulated. And so that is how IL-6 is controlled. So there is a complete video that I've done about it. Honor UKB says, question, are you aware of studies on ionizers? So here is that study. It is very interesting. So what they're talking about is, so there is a device in which they throw negative charge at the aerosolized particle. Those negative charged particles, for example, virus or the small aerosol, are then pulled by positively charged plates of the device. And that kind of tries to clean the aerosol. So that is a device, and they say that this device has been helpful. So I would have to do a complete talk about it, but here is the study that they say it works. So Honor UKB, thank you very much. Green Dot says this study shows that MMR booster shot may reduce the risk of severe COVID-19. Should we take it? So I have it open here. This is the one. So analysis of measles, mumps, rubella titers of recovered COVID-19 patients. And it says that if you have, so this MMR is also another study where we have been looking at the data, and some studies say it works and some says it does not. But at the same time, it is not harmful to us. So if you can get a booster dose and your health is fine that you can take it, then take it. It is so far trends positively. Rob from Florida, will you recommend that everyone get the vaccine, even school-age kids? So Rob, they have only tested the vaccines on 18 plus. So I would never recommend these vaccines to kids because they're not tested on the kids. So because of that, these are not ready for kids. Mark Desrosier says, hi doctor, how can virus vary in size? I've read that SARS-CoV-2 can be 60 to 120 nanometers. So good question, Mark. And just like we vary in size and shapes, viruses, especially the enveloped viruses, do it. And here is the reason. If you see here, what happens is the SARS-CoV-2 virus, when it enters our body, and here is the messenger RNA. Messenger RNA then allows more messenger RNAs to be formed. Those RNAs would then go into the ribosome and work with that and kind of make more proteins. And then those proteins, the viral proteins and the viral RNA, will be packaged in a particle. This process of packaging is done in our Golgi apparatus, or it can be done on the way out of the cell. So what happens is, if I can actually use a cloth or something, so let's see. Okay, so here, let's do this. Imagine this is our Golgi apparatus membrane, and the virus particles are sitting inside. So imagine they are sitting here. On the way out, they pinch a piece of this membrane, which was our membrane. It was our Golgi apparatus's membrane, and they just bud through it, and they pinch a part of it, and they take that with it, and that becomes their envelope. So some viruses would take a bigger piece with them, some would take a smaller piece with them. This is really a drop separating from the water. So sometimes there is more volume, sometimes there is less volume. That's all. So because of that, their size varies. But within the virus, the RNA and the other structures are similar amount and similar size. So that was a good question. Cool Bean 381, and we are almost done here. If a person has had COVID, are they safe to be around? Especially when a recovered COVID patient is re-exposed to the virus, is there any time that they can shed the virus while their body is fighting this new exposure? So, as I discussed before, number one, if somebody is actively sick, they may be contagious. So that is that. But if they have recovered and they have antibodies, then when they would have the virus in their mucosal membranes, there will be antigen immunoglobulin A's that would connect with the virus and try to neutralize it. If that virus and immunoglobulin A flies from their mouth and goes into ours, that would not do much. So should you stay away from them? If they have recovered, then no. And even if they get the reinfection and then they're going to shed that out, they would have IgE connected with those viruses. One, the load of the virus will not increase, and secondly, the virus which they would shed will have the IgAs connected with them. Vic Harvey says, has it been determined that the vaccine will need to be administered seasonally, like flu? Will 2 doses every season be needed? Not yet. And it will be determined if the SARS-CoV-2 started drifting, started changing, and we will have to then follow the changes and remake the vaccines. So not yet. Stephen says, question, what are your thoughts on singular? So Stephen, I actually did not know what was singular. So can you please send me a link? Coolbean381 says, I have been in fairly strict bubble since March due to my husband's heart failure. I'm trying to determine if any of our children, grandchildren are safe to be around. Is there a definitive way to determine if a person has had COVID? So short answer, no. And the reason for that, as I have been discussing today before as well, we are used to only test 2 things, either RT-PCR or antibodies. And if we once again look at it, innate arm, then let's say this is the humoral side and this is the cytotoxic side. Children can actually have the virus and then handle it through their innate arm and not have symptoms, but they still will be shedding it. So you can actually get the virus from the children who may not show symptoms. So the question here, is there a definitive way to determine if they had the COVID? One way that is standard is to look at their antibodies. However, it is possible in children that they do not show too many antibodies because their innate arm had taken care of it. So is there a right thing, right way? We do not have that cocktail of tests to be done to check the innate arm and the cytotoxic arm and the antibody arm to then collectively say this person has responded to the virus in the following way. But if you wanted to do something, at least get the antibody test, and RT-PCR may or may not be necessary. Antibody test will be fine. At least that would give you some idea. K-pop Super Strong says, even vaccines are arriving within months. We should still be vigilant to bring COVID down to 0. Yes. For me, a great holiday gift will be the most efficacious, effective drug that will save lives right now to avoid people from dying or going to ICU. What do you think, Dr. Bean? Very correct. Absolutely correct. And guys, can you see this? I'm not coughing anymore. So I do not know what it is. Maybe it is psychological. Okay. So a great holiday gift will be the most efficacious, effective drug that will save lives. Ivermectin was one of such things. Vitamins were such things as well. So you are absolutely correct that while we are waiting for the vaccine, we should still be, this is my anger with the CDC. I ranted in the beginning of the talk that they should do something. There are so many studies now. And then the 3 things are still unknown from the vaccine. How long will the immunity last? Correct. How safe it is for the most vulnerable, that we know, because they had, in both cases, more than 40% of the people were either in advanced age or vulnerable. And they actually showed very good results with them and very, very safe, similarly safe as with the younger ones. Will it protect us even when the virus mutates? Virus is mutating all the time. But if the virus mutates their antigen, the spike protein, enough that the B cell training is useless, then it will not protect us. Can that happen? Yes. And I have done that discussion many times that if virus actually changes their antigen, their spike protein, enough that our antibodies cannot work with it, maybe then the virus cannot connect with the cell as well, the ACE2, and virus is useless now, it is disabled now, and it would die within that person. So that will be a clever virus change where the spike protein changes enough to beat the antibody production, but still connect with our receptor. Yes, if that happens, then the virus will have escaped and we'll have to make antibody changes again. Vaccine changes again. And then Satish says, and Satish, I know that you've sent me some emails as well. Dear Dr. Mubin, hello from Dr. Satish Chugh. Hello back to you. You have not given any definitive treatment of pregnant females, especially in mid trimester. So I am going to fess up to this. I usually try to avoid um, small children's medications and pregnant females because I feel I'm not the right person to discuss their medication. It's a sensitive issue. It is two lives instead of one. It is a different physiology instead of normal. So they have to be looked at by their patient, by their doctor, and then done the right thing. So because of that, I avoid it. So I would still avoid it today as well. The best way is to talk with your doctor. They would look at their labs and then decide what is the right thing to do. Faziel Esa says, question, heard a video about the false positive of the PCR. Yes, so we talked in the beginning about it as well. I have heard lots of videos too. There is some part that is true, and then there is some part that is exaggeration. But it is true that PCR is not that good a test. So let me come here. There are just a few more questions here, and let's actually go to the live side here. We are almost 2 hours into it. So Barbara, we need to stop farming them. Sounds like a mink virus question. So Jem has a question. If ill with COVID-19 and taking ivermectin early on, is it necessary to also take doxycycline or any other kind of antibiotics and also add in hydroxy? No, not necessary. Ivermectin in kind of prophylaxis is fine by itself. If it is an early COVID-19, I think that is what you were saying. So then yes, add doxycycline with it. Hydroxy is not necessary. I have used them together as well, but my preference will be ivermectin with doxy. So Professor Mulazim Hussain says he's my teacher as well. To check monocytes count in children can help their status of infection and then later on IgG levels. So the monocyte count, sir, will not talk about specifically if they have recovered from COVID-19. Monocyte would be useful during the actual active infection, but not afterwards. So the situation, so I'm being very respectful. You are my teacher as well, so of course you know more than me, and you are a pathologist too, so of course you know more than me. However, the innate arm of the children, when they handle the infection with their innate arm, then there are three changes that their innate arm develops. One is the cross reactivity, second is more natural killer cells, and the third one is trained immunity. Monocyte count will not indicate any of those changes. And secondly, even if you can see the trained immunity, or if you can see the cross reactivity, or if you can see the natural killer cell count, we can still not tell if the innate arm is specifically reacting to COVID without having them to react to it. So that is a basic problem. L says, very useful discussion from me. Really great discussion from Cool Beans. You're very welcome. So let's see. There is a question from Passy. Question, do you think that the immunosenescence stage of elderly will cause the vaccination to not work on the elderly? So I just answered that question, Passy. They actually specifically wrote this part of the data that they had actually given it to elderly who were in that kind of a stage where immune system does not function as elaborately. And they saw that the vaccine triggered their immune system correctly. And the effectivity was, instead of 94 or 95 point something, it was 94%. So slightly low. So Passy says, could a T cell test detect the innate arm? The problem is with the innate arm that it does not react, just like B cells have antibodies against a specific virus. And so we can look at those antibodies that react with the virus. We have to find cells that react to the COVID or SARS-CoV-2. And for doing that, we have to harbor the cells from the body and then test them against the virus. And such lab tests are not formed. The research tests are available, lab tests are not available. So Iram Afshan says, question, what about the skin rashes after even 2 months of COVID-19? So the same problem, just like the children started developing the blue toes or the COVID toes, what happens is when the blood vessels start becoming disrupted, that causes the blood to skin to be disrupted, and that causes skin changes. This is if hypercoagulability occurs. The other possibility is that if immune system or the antigens have gone and lodged under the skin and then antibody reactions occur, that can cause some skin damage as well. But most probably it is because of the hypercoagulability. Mariesta Dershe, I'll do that. So Jim has already answered this one. Can you get the infection between the initial shot and booster? Yes. Can you get asymptomatic carrier between shots? Yes. Can you become infected even after the booster? Yes. So they start counting from 2 weeks after the booster. So that means they suspect that before that one can become ill. Guy, increase the humidity in your home with the humidifier, coffee from dryer. I am actually sure that that is what's happening. So today I had asked, just before I started, I had turned the heater off, but it was too late, I guess. Guy, I think you are spot on. Okay, so let's see. If more question, otherwise, let's just take care of the Twitter side, just 2-3 left there. E-Dog. Once vaccination is in blood, vaccine is in blood, can you get blood test independently to see all ingredients in here? So the vaccine doesn't go in the blood. It goes into the tissue, for example, deltoid muscle. From there, some of this would escape into the lymph and then possibly in the blood as well. However, after the vaccine, you can get the antibody tests, but they should start becoming positive after some weeks. So I guess you're trying to figure out that when the vaccine is given, can you figure out if the vaccine is there and it's doing, hopefully it is there because they injected it. And then you just have to wait for booster dose and after that. It will be interesting, E-Dog, to actually start doing antibody testing, let's say every week after the vaccine, to see when do we actually develop the antibodies. So Debbie Bass, you're absolutely correct. You can do an NK function assay to test those cells that can attack the virus. The thing is this, that those are not available on regular basis. So they are good and available for research, but you're correct. Robert Huffman question, are you familiar with boron? And if yes, what do you think? It inhibits 24,4-hydroxylase and increases vitamin D availability. I'm familiar with boron, but not this function. So Rob, I'll have to look it up and understand and then talk about it. So one more question here, then I'm going to go to the Twitter side. Question, now known that the virus infects platelets, do you think it could jump from platelet to immune cells? I was reading about platelet leukocyte aggregates. HIV uses platelet as reservoir as well. Anthony, I did not know that the virus can infect the platelets specifically like HIV type infectivity of the white blood cells. It can infect any cell which has an ACE2 receptor, but usually it triggers the platelets because of the vascular damage, which causes platelet aggregation. Can you share the link? Because I would love to read it. I think I just do not have enough data on that. So let's look at Twitter a little more, and then hopefully we are done. Weatherman says, any idea how widely the protocol put out by FLCCC, EVMS, etc. are being followed in the US? Not much. That is the heartburn on Dr. Marrick's part, that he knows that some doctors are using it, but it is not gaining that global traction even within the US that it should. So yeah, so hospitals and doctors are just don't get convinced on these things. We know they're all using steroids, but at a high enough dose, not at high enough dose. So I was talking with some patients as well, and the steroid that was being given was very low dose. The underscore DOC says, hello, I'm worried about messenger RNA vaccine concept because it sounds like a biohack to our own DNA and protein making systems. Since this type of vaccine is new, how can we know this won't have other long-term downstream issues? Will the body never stop making the vaccine proteins? So very good question and very simple answer. At least from the technologies they have mentioned, what happens is that here is a cell, messenger RNA arrives in our body, correct? So that is part of the vaccine nanoparticle. This RNA goes to the ribosome. Ribosome uses that to make antigen, which is the spike protein. That antigen, because it is a foreign antigen, gets displayed on MHC2 or MHC1 on our cells. So now let's look at your questions parts. So number one, it sounds like a biohack to our own DNA. So that's not true. The RNA that is coming in has nothing to do with the DNA. Even if it finds a way to go into the DNA, it cannot do anything because DNA makes RNA and releases it outward. RNAs, if they go in, they have no role here. So RNA will not do anything. Number one. Number two, let's say we want to make an RNA that would somehow be incorporated in the DNA and do something. We will have to send enzymes which are smart enough to haul this RNA, take it inside the DNA, cut the DNA open, insert the RNA, create the complementary strand, and then attach the DNA back and still keep the cell normal, because as soon as the DNA becomes abnormal, the cell is going to die. The cell is going to kill itself when its machinery becomes damaged. So that's not going to happen. So the biohack on DNA is not the correct way to think about it. Then, since this type of vaccine is new, that is true, how can we know this won't have other long-term downstream issues? We do not, because it is new. Will the body never stop making the vaccine proteins? That is not correct. So here, when the RNA arrives in the cell produces the antigen, the spike protein. The spike protein is displayed outside. Now there are two possibilities. If this is a normal, regular cell, it is not an antigen presenting cell. For example, it is not a dendritic cell, macrophage, or B cell. Then the cytotoxic T cell, CD8 plus T cell, that would connect here is going to kill it. It will trigger the immune system, but it is going to kill this cell as well. This RNA is going to be destroyed as well. Even if this RNA comes out, it is not easy for this RNA to get back into the other cells because it needs some kind of a lipid nanoparticle around it to allow it as a vehicle to go in the cell, just like zinc needs to go in and it cannot, and we need some kind of an ionophore. Once the RNA is out, it cannot just penetrate back into the cell. If that was the case, we would not need lipid nanoparticles. So that means if the RNA comes out, it would be ingested by the other cells, for example, macrophages. They will eat it up, phagocytose it, and present it outside as well, and trigger the immune system. But this will not cause any issues. So when we look at this, will the body never stop making the vaccine proteins? No. Body would stop because the RNA is not going to be there forever. Dan says, I have read that even though the vaccine trials had upwards of 30,000 subjects, they stopped the test once they had results from around 150 people. Is this true? True, but the question, the context is important. What happened was this: 30,000 people, 15,000, for example, I'm just rounding them, got the vaccine. 15,000 got the placebo. Correct? Now, let them out in the wild, let them be at their work and do whatever they were, and then wait for them to get infected. When 150 people become infected, then that is a number that, when analyzed, will provide statistically significant answer that was the vaccine useful or not. So it is not that when the 150 people got the vaccine that they stopped. They gave it to 15,000 and they gave placebo to 15,000. Then they waited on them. And when 150 infections occurred, that is when they stopped observing further. I'm sure that they're still observing, they're still collecting data, but this was the milestone where they were allowed to then look at the data and see that this 150 people's infection, how many here in the vaccinated and how many here, and then compare them and then produce the statistical data to say vaccine worked or not. That is what happened. Satish, Dr. Satish, there's a lot of confusion and controversy in choosing between dexamethasone and methylprednisolone. In my practice, I am using methylprednisolone, oral 24 milligram BID, and equivalent dose of 6 milligram dexamethasone, being refuted by certain quarters. Your comments. Dr. Paul Marek prefers methylprednisolone because it has better penetration for the pulmonary tissue. So he actually says using dexamethasone is incorrect, use methylprednisolone. On the other hand, Oxford's trial tested dexamethasone and came back and they said dexamethasone definitely reduces mortality. So because dexamethasone has data behind it, that is why people support that. And then Avox Coffee Bean. Hello, doctor. 2 questions, please. I don't recall seeing the mechanism by which a long hauler from a dysregulated immune system would cycle. It goes away, it comes back. How does that occur? If this is already in a video, please tell me which I can watch. No, so I have not talked about the cycling of the system. So cycling is very simple. One mechanism to explain that is, let's say the immune system goes nuts and it is mad and it starts taking care of some cells and the viruses and it is upset about them. And it has taken them and it has worked on them and it has reduced their level. Then the immune system goes to sleep and says, fine, I've done my work. Meanwhile, if the virus is now increasing or if whatever tissue is now increasing, then the immune system would go back into a cycling state. This would happen, for example, if the virus is sitting in the GIT, or if the virus is sitting in some sort of cells, or if the virus is broken virus pieces are sitting in cells that are replicating and taking the pieces with them. So that is one possibility. The immune system cycling by itself can also happen where the virus is not the problem. The immune system itself is the problem. And what happens for that is that the way our system structures are built, these mechanisms, that let's say here is our immune system, all of it represented in this circle. When it becomes active, let's say this is now an active set of the cells for the immune system. Always with the activation, another set of cells is also started, which is the one that would regulate them and suppress them. This is always how it happens. Whenever we start inflammatory or immune reaction somewhere, that is combat or fight, we always start the regulatory system with that would suppress it. Now, so let's say this guy is working and it doesn't know that we are a long hauler, so it is just causing damage. Then the suppressor system becomes activated in 3-4 days. Suppressor always, it is started at the same time, but it reacts after a delay so that the activation system can do its function, take care of the virus or do the inflammation and take care of the problem. And then the suppressing system would become active and say, now you stop, you've done enough. So let's say the suppressor becomes active and stops this. So now this wave or cycle is gone. And then this guy becomes mad again. So now what causes it to be mad? Was there enough cytokines present? Was there enough broken tissue debris was present that even when this suppression occurred, this thing is going to trigger this guy again? They would then within 2-3 days again start this thing, and the cycle just continues to happen. That is the more probable one than the virus itself. Number 2, when I see speakers, they always have water. So Evox, in your honor, I have water now. They always have water. When I watch you, I have water. Luffy has water, but I see no water for Mubin. Why no water for you? So got my water. Thank you. Gem, I've seen the iMask Plus PDF on the Frontline COVID-19 Critical Care Alliance site. Question, if one is treating for outpatient protocol as indicated on the FLCC Alliance PDF, would it be beneficial to add an antibiotics like doxycycline or Z-Pak and even possibly hydroxychloroquine? Doxycycline, yes. Don't need Z-Pak. I've seen the doxycycline to be a better combination. Hydroxy, your choice. If the patient can do it, hydroxy would only benefit with zinc and can be added, but you have to make sure that the patient can take it. So last few, man, we are now today, we are too much over the time. My apologies. I hope you guys are okay. Iron Wolf, taking the vaccination should be exposing your body to the virus in a small amount, yet people have been terrified of even being near someone who has it. How does this make sense? And wouldn't that make asymptomatic people walking vaccines? Very good question. And the basic comparison is incorrect, Iron. So you are comparing a vaccine to an active virus. Imagine a pile of hands, just hands or gloves, pile of gloves, which look like hand. And then people with hands with knives in them. Who would you rather be near? The one with the hand and knife, an active person, or the one that is just nothing but a pile of gloves? The vaccine only produces spike proteins, a bunch of spike protein that is like a pile of gloves that tells our immune system to be wary of something like a hand spike protein. But if a virus actually has enzymes in it, actually has whole RNA that would make RDRP and make viral cargo and make our cells defenses be stripped down and then make copies of itself and then become assembled and then go out and then penetrate other cells again, that all an antigen produced by vaccine cannot do. So that is why the asymptomatic people or any infected person is not a walking vaccine. They are contagious and they can give you the disease, but a vaccine cannot give you the disease. James Kelly, hello sir, please do a session on the trace molybdenum, chromium, copper and lithium important in psychiatry. All right, will do. Tony Karalikas, cool beans, if a percentage of long hauling was caused by a viral persistence, some do not respond or get worse with steroids, should the messenger RNA vaccine offer hope? Body forced to present the antigen, make antibodies, clear virus. Seems like some long haulers are stuck in innate arm of the process. So Tony, the answer is, if it is because of viral persistence, then yes, I would ask this question first. We have the live virus in the person and the immune system is not responding. What makes the antigen better then? Why would antigen be triggering the immune system when the actual virus was not able to, and virus is still causing symptoms? That means it is increasing in number and it is causing an issue. So in my opinion, the long hauling is not the viral persistence. Long hauling is immune system going nuts. Vic RV says that would it make more sense to give hydroxychloroquine in the ivermectin treatment prophylaxis protocol than quercetin, since hydroxychloroquine is a better zinc ionophore and higher doses of quercetin are required to match the effect of hydroxychloroquine? So very, very good question. That should we just use hydroxychloroquine as an ionophore? That means we can use it in lower doses. It only acts as a zinc ionophore and allows the zinc to go in. If that is your intent, then yes. But please know that hydroxychloroquine is not used only for zinc. This is a incorrect theory that has developed, that the only function of hydroxychloroquine is to allow the zinc to go into the cell to do RDRP damage. I have talked about 6-7 mechanisms of hydroxychloroquine that are all relevant to the COVID-19 management. James Kelly says, I keep looking up. So last two questions here, then I'll come there. James Kelly says, hello, Dr. Bean. Can you explain the difference between arginine and levoarginine as per the question yesterday? Also, do you know 9F, any databases or enzymes? So there are many databases and enzymes which are owned by various companies. So normally they do not open them up outside. That is one. And secondly, arginine and levoarginine are actually the same thing. So I have the article here that arginine, also known as levoarginine, is an amino acid. So they are both the same thing. We just call them arginine. Julian Charles says, lots of great advice from many doctors, D3, K2, CB, complex quercetin, and so on. But can we combine all these safely, or do they conflict? Most of these can be combined safely. However, what we should do is to look at cytochrome P450 or other liver enzymes to see which drug modulates them, and then see what can they do. For example, some drugs like ivermectin or hydroxy can modulate some liver enzymes, which would make other drugs not safe or less safe. And so we should look at those before we say combine them all. Okay, so that is the side on the Twitter. We are 2 hour 20. This, nobody's gonna watch this video other than the folks who are here. All right, let's see what we have here. I have read, so some more questions, couple of more questions, and then we break. Sorry, it has become so long. Jem, thank you very much. Shock, thank you very much. Jem says, for educational purposes, if human and taking 1.87 horse pace, it's super important to understand dose of human, which is micrograms, and dose to weight. Yeah. So no comments. Thank you very much. So Closet Picker says, but Dr. Bean, the water only works if you sip from it. Your jar is still full. Yes. There you go, Closet Picker. Thank you. I think that is it. I think we have actually answered majority of the questions here and on Twitter, despite all the cough and everything, or cough. Logic question, can you touch base on beta glucan 1316 alpha lipoic acid? So yes, I would talk about it, because there was another question about alpha lipoic acid as well. Cool. So Margaret says, yes, Barbara, about the mix. Thank you, Margaret. Margaret, thank you very much for your donation for Nina, and thank you very much for your support for me as well. All right, so this is it. So we have reached the best part of my teaching sessions, and that is the Q&A. Thank you very much. Even when it is 2.5 hours long, please like, subscribe, and share. if you can dare to share this one. And if you wanted to support this work that you're seeing, there is a link for donation in the description. Thank you very much. And please see if you can donate for Nina. We, I think, have reached 1,600 or 1,500, and there is another 1,000 that is needed. So thank you very much. Bye-bye, and see you tomorrow.